Good morning, everyone, and welcome to the COVID-19 Community of Practice for Ontario Family Physicians, the March edition, which is the theme, the letter M. We're going to be talking today about measles, Mpox, and menopause. Thank you all for joining. We're so pleased that the Ontario College of Family Physicians and the Department of Family and Community Medicine are able to continue providing these sessions for our community. I'm going to turn things over now to Dr. Mekalai Kumanan to open up today's session on behalf of the OCFP.
Thanks, Ali, and good morning, everyone. Thanks for joining us. We do have a great session lined up for you today, and I'd like to just take a moment to thank our panelists for being with us, and a reminder to you that this is a MainPro accredited session. Next slide, please. So just moving on to our land acknowledgement, we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite us all to reflect on the territories we are calling in from as we commit to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Kitchener, the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Chinantan peoples.
Next slide, please. So I'll provide the reflection for today. So I don't have any slides particularly, but just wanted to share a story. So earlier this week on Wednesday, I had the privilege of joining our colleagues at the Indigenous Primary Healthcare Council for the Traditional Healing Advisory Circle gathering. I was invited to attend this particular event due to my role with the Foundation for Advancing Family Medicine, where we've partnered with the IPHCC to provide funding and grant opportunities to do more research into traditional healing and how that fits into the models of team-based primary care. And it was just such an incredible opportunity. And I just wanted to share a little bit about it. It was this phenomenal event where they showcased so many elements of Indigenous culture from around Canada. I saw performances of Inuit throat singing, the different types of music styles. I saw traditional ceremonies as well. There was also a group of dancers who was a family of dancers, and they were all kids, and they actually have been on Canada's Got Talent and have this very unique style of dance that they performed and taught the audience how to do as well. And it was just an incredible opportunity to be able to witness that interface between culture and healthcare. And I really left that event just really trying to understand more and wanting to understand more about how culture contributes to the healing process and how we as family physicians can be really involved in creating space and supporting that. And I think the work that's happening is an example of that. So I just wanted to reflect and also to share my gratitude and thanks to our colleagues with that particular organization for allowing me to be able to see that. And I encourage everyone else as well too on this call to think about opportunities where you may be able to experience culture and be able to understand these things a little bit more, because I think that through greater understanding, we can move towards greater truth and reconciliation as well. So those are just some of my thoughts for today. And so with that, I wanted to move us along to this particular slide, which again, it just details that this is an accredited session and also that you can access previous webinars through our website. Next slide. So we have a great set of panelists. They're going to introduce themselves shortly. So we'll just move on to the next slide. And next slide again. And at this time, I'll have them each introduce themselves in turn. So if we can just go back one slide, and we'll start with Dr. Chagla.
Get off mute. Hi, everyone. I'm Zain Chagla. I'm an associate professor at McMaster University and in medical director of infection control at St. Joe's Healthcare in Hamilton. And those are my disclosures. There will be some discussion of vaccines, but they will be on-label or guideline recommended indications.
Thanks so much. Over to you, Dr. Goldstein.
Hi, good morning. Thank you for having me. I'm Sue Goldstein. I'm a family physician in Toronto. I am a Menopause Society certified practitioner, but I do practice primary care. I sit on the executive board of directors for the Canadian Menopause Society. These are my disclosures for speaking or ad boards. I did receive an unrestricted educational grant from the Canadian Menopause Society, which supported the development of the MQ6 website I'm going to talk about today. And in terms of conflicts, everything I'm talking about is guideline and evidence-based, and should I speak to anything that is off-label, I will clearly indicate that. Thank you.
Thank you. Over to you, Dr. Warshafsky.
Hey, good morning, everybody. I'm Daniel Warshafsky. I'm the Associate Chief Medical Officers of Health in the ministry, and I don't have anything to declare.
Thanks so much. Dr. Kumanan.
Hi, everyone. My name is Mekalai. I'm a family doc in Cambridge. I'm currently serving as the president of the OCFP, and I also serve as a deputy chief of family med at the Cambridge Memorial Hospital, both of which I receive a stipend for, but neither of which poses a conflict for today.
Great. And as for myself, I'm Ali Damji, Division Head of Primary Care at Trillium Health Partners and a family physician. And I receive honoraria from the OCFP to moderate these sessions, but that, of course, does not pose a conflict for today. Next slide. So for those of you who are new to the sessions, for question and answers, you need to use the Q&A function within the Zoom. So please make sure to use that button and submit your questions. I already see someone has started that, so that's wonderful. And then if you are wanting to submit a question too, feel free to take a glance through what's already been asked, and you can press the thumbs up button to upvote a question. As the moderator, I'm looking for the questions that have the most votes to ask first. So if you see a good question and you want it answered, feel free to upvote it rather than putting the same question again. Now, one thing about today's session is that we got a ton of questions about menopause, but that's going to be the second part of today's talk. So what I would suggest is that if you have some burning questions about menopause, feel free to put them in even now. And our panelist is actually going to start answering some of them too. And then I will also speak to some of the answered questions out loud. So those of you who can't see what's going on will be able to hear what those responses were. So we're going to try that a little bit differently this time. So please feel free to put those questions in up front. And then the chat, feel free to use for networking. And so with that, I'm going to turn things over to Dr. Chagla, who's going to get us started.
Hi, everyone. Thanks again for having me. I'm always happy to be here. So today we're going to talk a little bit about a respiratory update, but the bulk of the focus will be on measles. Next slide. So in terms of respiratory activity in the province, we see COVID-19 percent positivity, which is probably our surrogate marker for community transmission. I'll go through wastewater and hospitalizations in the next slide, but is coming down. Oh, sorry, slide back, go back to the last slide. Yeah, perfect. Influenza A and B are starting to peter out as well. We do see human seasonal coronavirus, so one of the common cold viruses, starting to increase, as well as human metapneumovirus and a small amount of entero and rhinovirus as well. Next slide. In terms of hospitalizations and outcomes from COVID-19 in Ontario, we see that, again, things are declining. So on the diagram on the left, the highest bar is all COVID-19 patients in hospital beds. The one slightly below that is people admitted for COVID-19 or people in hospital because of COVID-19. And then the last two bars are ICUs and deaths. And again, a small increase in activity from the ICU and death standpoint prior to February of 2024. Some degree of hospitalizations, although much of those numbers are starting to come down into March. We can see the wastewater signal here, and this is it was updated yesterday, which essentially still shows a flattening or decline that is coming down again from a high level of activity from the late fall, early winter. Next slide. So the one thing that is coming through the guidance is the spring immunization campaign. And in fact, although NACI had released its guidance about a month and a half ago, the province has released their guidance actually yesterday around this. And so the provincial recommendations for spring, usually using the NACI recommendations, adults 65 years of older adults in long-term care or other congregate living facilities, anyone over the age of 6 months who are moderately severely immunocompromised due to an underlying condition or treatment. And then Ontario has added individuals 55 or older who identify as First Nations, Inuit or Métis, and their non-Indigenous household members who are 55 years in age and older. The recommended interval still is 6 months, either post-infection last vaccine, 3 months minimum. One question is always, well, not many people are testing. People have had upper respiratory tract infections over the last few months. And again, use clinical judgment, but unless, realistically, unless they've had a positive COVID-19 test, you wouldn't necessarily count that towards that 6-month interval. Other immunizations. So just a reminder about the RSV vaccines and for 2 vaccines on the market, GSK and Pfizer's vaccine. The Arexvy vaccine was the one that was approved in the early fall. This is indicated for those living in long-term care, elder care lodges, funded for those living in those in these settings. So long-term care, elder care lodges, retirement home, hospitals getting ALC, hemodialysis, or PD, hematopoietic or solid organ transplant, those experiencing homelessness, and those who identify as First Nations, Inuit, or Métis. Everyone else, it is indicated for those over 60, but not funded. The one change that will be happening probably in April or May is there will be another vaccine coming to the market in Brisbane. This was approved for 2 indications, greater than or equal to 60, and for pregnant individuals between the ages of 32 and 36 weeks of gestational age. And the indication for this vaccine is not for the protection of those pregnant individuals, but for actually the protection of their fetuses and eventually their children, where clinical trials have suggested a moderate benefit in reducing RSV-associated hospitalizations and healthcare utilization for individuals that receive this vaccine and their neonates make it to term. The good news is both vaccines, especially in that over 60 group, have had 2-year data released that suggests greater than 70% efficacy against moderate RSV. And so, as you're counseling patients, this is likely at least a 1-shot vaccine for the foreseeable future. But reassuring data, at least from 2 years, that really holds true. Next slide. So moving on to measles. What the situational change that's occurred globally, and this is a report from the ECDC, the European CDC. We've always had endemic measles transmission through sub-Saharan Africa, through Southern Asia, Central Asia, and Southeast Asia. The difference, I think, over the last 10 years has been an increasing activity through Western and Eastern Europe. And that really has led to a challenge because, a lot of those destinations are destinations that Canadians visit during time. And so in the context of travel, there have been a number of important cases, both from those traditional settings where measles transmission has been endemic, but also more highly resourced settings where measles transmission was not endemic until the last few years for a number of factors. For the ECDC, at least up till December 2023, you see the burden of who is getting measles amongst these outbreaks in Europe. It is predominantly younger children, particularly under the age of 10, where many of them have not been immunized, some of them obviously by timeline in the 0 age group, but some of them that are missing publicly funded vaccine campaigns. There is a small degree of people who are vaccinated that are also suffering from measles, but the vast majority of the cases are occurring in children under the age of 10. Next slide. So to remind everyone, the clinical presentation, so the typical prodrome, and this occurs about 7 to 21 days after infection. We do consider people infectious post day 5 in terms of infection control, and we'll mention that with post-exposure. In the classic syndrome of fever, malaise, cough, coryza, conjunctivitis, the coptic spots that show up 2 to 3 days after symptom onset, and I have a picture there. And then the maculopapular rash, 14 days after infection, that typically starts on the face and progresses down to the trunk and arms and legs. I will mention, and I have some pictures here, that post-vaccination measles, so people who have had a vaccine series that do develop a breakthrough infection with measles, may have very variable rashes and a mild clinical course. So, don't use the maculopapular definition is a great definition for the classic rash, but consider the other rashes in the context of people that have been immunized from measles. Next slide. So these are the classic images. On the left, it's the coptic spots. It's a little bit hard to see here, but the kind of whitish spots on the buccal mucosa. Here's just a demonstration of classic measles in children of different skin types. Really recognizing, again, the burden is actually highest on the face. So it is kind of atypical in the vaccine naive individual to not see the face involved and to a higher degree than the rest of the body. And then the classic macular papular rash that progresses down. Next slide. So this is some interesting cases and pictures around post-vaccination measles, just to keep in mind. So this is a case series of individuals with post-vaccination measles. Most of them had very good titers to measles going in. And you can see here that the demonstration of all the symptoms is completely variable. Some people only had fever, some people had cough and fever, some people didn't have conjunctivitis. So again, don't use those as exclusionary tools in individuals that are fully vaccinated. The macular papular rash was only present in one individual with post-vaccination measles. And in fact, the other individuals here had a modified measles rash, which appeared as pinpoint and vesicular. And so you could easily look at this and say it may be an allergic rash or a dermatitis, just to keep it in mind in the right context, especially someone that's traveled, that this could be a measles case in that context. Next slide. And these are just some more images of another individual. So you can see kind of a vesicular rash along the hairline, along the neck, and the armpits. Again, could be very classically missed as a dermatitis or some other mild eruption. And so, again, please, be cognizant, especially if there's risk factors and exposure, someone who's traveled recently with a fever and a rash, that measles still remains in the differential, especially in a vaccinated case. Next slide. Testing. So the diagnosis is made by a combination. I will say, the combination is as important, particularly the molecular tests. So nasopharyngeal swab or throat swab and urine PCR. The serology is also helpful, a little bit less helpful in the context of vaccinated individuals, especially if they're receiving post-exposure prophylaxis, where they're also getting vaccinated as well. But the recommendation is to collect all three specimens for every individual patient. We've had some challenges, I think, even in my setting, about serology being the one that's relied on the most. And in fact, it's the opposite. Serology is probably the least helpful of these three tests, and the molecular tests are probably more helpful. So just, again, a reminder that all three are collected. Process through Public Health Ontario. Contact your local public health unit if you have suspect cases, partly to start the person under investigation, but also to help with expediting the samples and working through the process of getting these to public health. The turnaround times are excellent. So again, collect them and you can get results relatively quickly. The one caveat I will say is some of the viral swabs that are out there are expired. The media is expired. This was acceptable for viral infections like COVID-19 and influenza, where there was some validation that was still appropriate. But for measles, this is not validated. And so if you are to use expired media for that throat or nasopharyngeal swab, it will be rejected from public health. And so be cognizant, especially if you do encounter a case or need testing or developing your plans, that you have kits that are not expired. And if you do only have expired kits, then reach out to the ordering center to make sure that you have some on hand. Next slide. For infection control, all measles, all healthcare workers that are working with patients potentially that have measles should be immune. So that's either 2 doses of a vaccine, laboratory confirmed infection, or serologic evidence of immunity. Important here, this is regardless of year of birth. So I know in the general population, we use 1970 as the cutoff. In this context, that is not appropriate, and you should be either documenting immunity or making sure the vaccine schedule is up to date. Only healthcare workers with presumptive immunity should care for measles cases. One change that occurred, and this was based on a lot of confusion around what the appropriate PPE based on other national and guidelines. Prior, there was a consideration for immunity for the type of mask that was worn. Given the simplicity and again in the context of just precaution, the appropriate PPE for the care of a measles case is a fit, tested, sealed, checked N95 respirator, regardless of immunity status. So optimally, everyone should be immune who's dealing with these cases. But even if they are immune, they are using an N95 respirator as part of their care. If possible, particularly in settings where it's available, use an airborne infection isolation room. And again, additional PPE based on risk, make sure that, especially if they're, having diarrhea, consider wearing a gown, or if they're expelling a lot of body fluids in the environment, consider eye protection as well. Next slide. In terms of the office, so, I will say, it's as best as possible, try to see these people in outpatient settings. And, contrary to other medical issues, which are significant and serious, the ED and urgent care may actually be a even harder location to send these folks, because they are exposing a significant number of vulnerable patients in a small period of time. And so, as best as you can, trying to get them diagnosed in the community to really kind of minimize the exposure risks in emergency rooms. And we've had, unfortunately, some of that occur already. So in the office, if you're going to do it, schedule them at the end of day when rooms are generally emptied or waiting rooms are emptied. Give them patient hand hygiene. If they can tolerate the mask, then wear a mask. Put the patient immediately in a single room and close the door. Really curtail movement in and out of that room for that patient unless otherwise necessary. Recognizing that most people don't have an airborne room in their office. When the patient leaves, close the room. And most rooms are not appropriately air exchanged, so use a 2-hour closure with the terminal clean afterwards. When you test patients, tell them to await their laboratory tests in isolation. They're infectious 4 days prior to the rash to 4 days post-rash. And for those individuals, avoid all non-household contacts, so they shouldn't be going out in public. And if there are high-risk individuals in the household, like pregnant individuals, people who are immunocompromised, they may also want to avoid them. Unfortunately, household contacts are probably exposed at this point, but there is the ability to at least minimize the circles of transmission. Next slide. Last slides are on post-exposure prophylaxis and immunization. So these are the recommendations for post-exposure prophylaxis, and they're available. I'm not going to go through each one individually for the sake of time. The next slide also has them summarized in a nice diagram. Maybe flip to the next slide. Yeah, there we go. So again, if you do have cases, feel free to reflect back. These are available to the province. The vast majority of immunocompetent people are offered MMR as their post-exposure prophylaxis. It's only in infants who are past the timeline, or infants under the age of 6 months, or pregnant individuals or immunocompromised individuals that they would receive IVIG, or if they're under 30 kilograms, IMIG. Next slide. Lastly, prevention. So measles vaccination, lots of questions, obviously. So for those who are 6 to 11 months, they can receive it when traveling to an area of concern. They still need their full series. The Ontario funded vaccine schedule is greater than or equal to 1 year of age, and then MMRV at 4 to 12. Those greater than or equal to the age of 26 years of age can receive a publicly funded second dose who have received either one vaccine and are either a healthcare worker, a post-secondary student, they're traveling, or based on the clinical judgment of their providing clinician. The minimum interval between vaccines is 4 weeks to 1 month. And so For those who are doing catch-up series and want to be immune relatively quickly, they can again do that. If you're using MMRV, the interval is a bit longer, 6 weeks. And then really, you know, the big question is who to focus on. Kids are the big one. And you see in that data from ECDC that their outbreak is largely involving kids. And so, you know, kids that are on schedule are the ones you really, really want to get in as aggressively as possible. Kids that miss vaccinations, kids that are from remote settings. There's data from Canada, the Public Health Agency of Canada, suggesting kids that are Black and Indigenous who are remote to healthcare and are of low socioeconomic status are the ones that are higher missing their routine vaccine series. And so really, if you're dealing with those populations, please, you know, those are the ones that you really want to reach out to. Obviously travelers as well, but, you know, travelers who have received their prior vaccinations are relatively protected going forward. Next slide. And with that, I'm going to switch it over to Daniel.
Thanks, Zain. All the questions about measles, so I'm going to try to get through these quickly, like for the Mpox stuff. But I just wanted to give a quick update because we're seeing a significant increase in Mpox cases. So next slide, please. So just key points, just make sure we're still considering Mpox, particularly for the at-risk populations. We'll talk a little bit about what ordering should be done, and that just anybody who is in the eligible populations continue to recommend that they're vaccinated. We're still seeing most cases are people who have not received any doses of infant vaccines. So it's a great opportunity to remind people. Next slide, please. So just in terms of what we're seeing, we saw a big bump in cases of Mpox just in the last couple of months, 28 cases that were confirmed compared to 33 total from all of last year. So it's a pretty big spike that we're seeing. Still the same population previously, so predominantly male, predominantly living in the Toronto or GTA region, and most common risk factors are still sex with same-sex partners or multiple sex partners. And still, the vast majority of those cases have been completely unvaccinated or had only one dose, as opposed to completing the entire 2-dose series. So this is the wastewater signal, just showing that it's following along in terms of seeing that increase in Mpox. So you can see all the red spots in the February, indicating that we are seeing quite a bit of community transmission, probably in addition to the cases that we're seeing, although it might be letting up now just based on the last couple of weeks. Next slide, please. So when to consider Mpox? That's really the question today. So if we go to the next one, just a quick review of the symptoms. So, you know, viral disease that comes with some of the similar prodromal viral symptoms that we see with others, fever, headache, sore throat, cough. It's really the Mpox lesions that are the hallmark for identifying whether or not someone has Mpox, in addition to careful history about their potential risk factors. So next slide, please. So Mpox lesions. And this looks very different, as Zain said, similar to measles, different for someone who's been fully immunized versus someone who hasn't before. Mpox lesions progress through a couple stages. They start with that more pustular appearance. They then develop their central umbilication, and then they eventually crust over the course of 2 to 4 weeks. And the timing can differ just depending on the individual. Next slide, please. Quick comparison between multiple lesions. For me, like the middle stage of Mpox looks a lot like molluscum, but molluscum's not going to crust over at some point. But you can see there are certainly similarities between a lot of these, and even the atypical measles presentations that Zain was talking about. So again, a careful history is really the key to some of this. Next slide. So what do you do if you think someone has Mpox? Next slide. So number one, in terms of IPAC, Mpox is primarily contact spread. That's been the vast majority of cases, but there is some level of droplet spread that can occur. So the infection prevention control practices are the same as that we use for COVID-19. So if you do suspect someone of having active Mpox right now, ideally try to get them into a room so that they aren't potentially spreading to other people in the hallway. You'd be following droplet contact precautions for anyone there. Please provide a mask to your patient as well. And then just routine environmental cleaning afterwards for any room that's had someone who potentially has Mpox in it. Next slide. You can all test in the clinic. So it's a PCR test. What we ideally do is swabbing of lesions, multiple lesions, if there are available for you to do so. At the same time, opportunistic testing for STIs is recommended to be offered. Again, not specifically a sexually transmitted illness, but most of the Mpox cases that we've seen, again, are transmitted through intimate or sexual contact. So it's a good opportunity to remind any patients about that. The PCR testing form is kind of the standard Public Health Ontario form. I think in the slides that get posted, you might have an example of it, but you just fill it out for Mpox. In terms of management, it's primarily self-limiting. So most people get, particularly with the outbreak that we've had in the last couple of years of Mpox, has been a little bit more mild than some classic presentations of Mpox, and supportive treatment mostly. For some individuals who get severe symptoms, so there have been a few cases in Ontario who have gotten things like significant oropharyngeal ulcers, difficulty swallowing, or significant genital ulcers that are causing a lot of pain. There is an antiviral treatment available. However, it's in very, very short supply coming from the federal stockpile. If you do think a patient might need it, the details on how to order are up on the ontario.ca website with our Mpox guidance. And as well, there's a trial ongoing primarily in Toronto, where they have TPOXX available for patients, where we're trying to get a really good assessment of how well it's working for these new Mpox cases. But what to tell people if they do have Mpox, they should be staying at home until the lesions have all scabbed and fallen off. Once they get past that point, then they're no longer going to be communicable, and then they can return. Depending on how significant the lesions and symptoms are, some people can return earlier. If it's a very, very small area, sometimes it can be covered up and they can return back to work depending where they're going. But if it's more widespread, or particularly if they're dealing with more vulnerable populations, young kids, people who are immunosuppressed, pregnant individuals, then better to stay home until symptoms are completely resolved. And again, if they are going to be seeing people, ideally they should be wearing a mask for source control of any potential droplet spread. Next slide. And so for public health, Mpox is a reportable disease in Ontario. If you do have a patient who are considering Mpox, please let the public health unit know as soon as possible. The labs will report positive results, as we know, but it's helpful for healthiest to be able to know in advance so they can follow up and be prepared and begin any case and contact management as soon as possible so we can limit spread. Health units will follow up with cases and perform complete contact management for any contacts they can identify, and they'll be letting people know when they can enter isolation periods. Next slide. So quickly in terms of the vaccine, let me go to the next slide. So vaccine is available as both PEP and PrEP, so pre and post-exposure prophylaxis. This is the quick list here of individuals who are eligible for immune vaccine in Ontario. I'm not going to read it through, but again, it hasn't changed since the initial outbreak that we had. And again, really strongly recommending that any patients that you have in these populations are strongly recommended to get the vaccine. As I mentioned, the vast majority of cases still either have received 0 or only 1 dose. And we know that 2 doses provides really good protection, as well as significantly decreasing severity of disease if they do still catch it. Vaccine can also be offered as post-exposure prophylaxis. That will primarily be for people who are contacts identified from public health. But in case you have someone and it's within that first 4 days, you can consider that as well. Next slide. So again, key messages, consider Mpox, even though we're talking most about measles today and all the concern with measles, it still happens. And then just in terms of anybody who's in that eligible patient population, please encourage them to get vaccinated. I think that's it from me, Ali.
Wonderful. Thank you so much for that, Dan and Zain. Next, I'm just going to quickly ask Dr. Kumanan to speak to these next 2 slides on behalf of the OCFP, and then we'll turn over to Q&A.
Yeah, thanks, Ali. Just very quickly, the OCFP has pulled together a 2-page measles resource where we've tried to kind of capture everything you need to know. It outlines who may need an additional dose of vaccine and also kind of what to do if you have a patient where you suspect measles, and it links to the public health information that Zain has referenced. So you can find that on our website, and I think our staff have just put that link into the chat as well. Next slide. Just in follow-up, I think in the past I had updated everyone that the OCFP had pulled together this sick note resource that you can use when you're being asked to provide a sick note for a patient to help educate employers on why they should change their policy. This is now, this template is now able to be integrated into the various EMRs, so you can check that out on our site as well.
Great. Thank you so much for that. And I really appreciate that note there that it's also now going to be integrated with the at least three of the major EMRs there on the right-hand side. So just something to flag for our colleagues as well. So I'll just ask if we can just take the slide deck down so that way we can start the Q&A. That way we can see everyone. Perfect. Thank you. There's a lot of questions, especially ones related to measles vaccination. So I think we'll start with that. So my first question here is with regards to travelers older, born before 1970. What is the advice here? Can you guys clarify that for us? Maybe I'll start with you, Zain.
Go ahead.
Sure.
Yeah, sure. So, we use this 1970s cutoff in the Canada Immunization Guide to really describe, when endemic circulating measles was there prior. It's not a perfect measure, especially in people that are kind of peri-1970. Again, individuals, the recommendations from the Canada Immunization Guide are either proof of prior measles, proof of immunity, or a single dose of vaccine. There is, I would say, a little bit of discrepancy with the publicly funded vaccine schedule, so what people are accessible for, but maybe I'll flip that over to Dan in terms of what's available for that patient that calls who is born in 1965 that wants to be up to date with their measles and doesn't know if they've been immunized.
Yeah, sure. I can add quickly. So every adult is eligible for at least a single dose of publicly funded vaccine. So for someone born before 1970, they would still be eligible to receive it. I think, to Zain's point, the question is how much they really are going to need it. If they probably had measles, they think they had measles, they get lifelong immunity, or even if they're in that age where they've had a single dose. I mean, a single dose of measles vaccine is very effective still. CDC quotes 93%, but anywhere from 85 to 95% at preventing measles infection. So, that older adult traveler isn't really the highest risk. It's predominantly kids. Like, it's unimmunized kids that we're really trying to focus on.
Yeah, and definitely hearing that message loud and clear from both of you around really focusing on the kids. And that brings me to this next question here, where there was a CBC article that was talking about potential shortages of the MMR vaccine. Of course, when something like this comes up, we run into these challenges with supply. So, when we're having these types of concerns, how do we navigate this? I'm curious. What's your advice here?
I can just start by addressing shortage potential concerns about that in the province. So we did hear that the private market MMR vaccine, there has been experiencing a shortage. I think MMR and MMRV actually. And that should be getting addressed in the next few weeks to months. In terms of our publicly funded supply, we don't have a shortage in any way. That said, there is still a finite amount of vaccine that exists within the province and with the country. And if we're all rushing to immunize older adults with a single dose that aren't urgently needing it, again, trying to focus on the kids with the supply that we do have. But no shortage of publicly funded supply, to be clear.
Great. Thanks for clarifying that. That's a relief. So in terms of other aspects around administering MMR, do you know if there's any discussions to allow pharmacists to administer the vaccine, as currently they're not able to do so?
Probably for me too. So it's a really good question. So there was quite a while ago some proposals that were going around about what expansions to pharmacy vaccination capabilities could happen. I can say, most people felt that pharmacists being able to perform routine childhood vaccines was probably not a great idea, given the current system, the lack of a registry, way to easily transfer records, all those things. So it's not in the imminent future to have pharmacists providing MMR.
Great, thank you. And then another question here about the healthcare workers in terms of them being higher risk. So Zain, you did touch on that in terms of if they were not fully immunized and the risks with them and essentially that they would need to be caught up or they can't see measles patients. But has there been any questions or comments around giving a third dose to those healthcare workers, or is that not necessary?
I think it would be individual basis. The one thing, at least hospital-based healthcare workers, a lot of them do require serologic testing or proof of immunity. So those who have inadequate serologic testing may be offered another dose as part of that. But recognizing that 2 doses is still probably pretty adequate for the vast majority of individuals, including those caring for individuals with measles. I mean, we are, have had several cases of measles in the province. All of them have required care at some point or another as part of their diagnostics, and have yet to see healthcare worker transmission in this context. So just to say that, that current protocols of just having the 2 doses appropriately, unless people have not had a response, is pretty reasonable for most.
Mm-hmm. And I guess that leads into another question, which is often not just from healthcare workers, but from other patients as well, too. We often get requests for serology as well, too, to confirm immunity. Just wondering if you guys could, either of you could clarify exactly what the advice should be or what we should be recommending when we receive those requests.
I'm happy to start. So I would, from a practical standpoint, say please don't overload the lab with serology requests. The public health laboratory is working diligently to get through measles diagnostics for high-risk cases in a time-appropriate manner. If you have, there may be settings. So, for example, healthcare in hospitals and emergency rooms, et cetera, where there's going to be a high chance of exposure, where serologic testing, especially in people with unclear records, may be very warranted. But for the average individual who's out there, just follow their vaccine recommendations. So if they're under the vaccine recommendations, put them at the vaccine recommendations. Because again, using a $20 or $30 test for hundreds of thousands of individuals, where the answer would be to just immunize them appropriately, it's probably just easier and cheaper and much less resource intensive to just immunize them appropriately.
Great, thank you. So another question here around pediatrics. So if you immunize someone early with the MMR vaccine before 12 months, so let's say, as a child who was traveling, as you said, and you've done that, now what's the interval then for the usual 12-month shot then? Like, how does that work? Does that affect anything?
So it's a month between shots as the minimum. So if you did it at 11 months, you could give it at 12. If you did it at any 6 months, you could do it at 12. It's really if you were under that 11 months, so kind of 11 and a half months, that you'd have to re-immunize after 12 months in that sense.
Perfect. Thank you for that. Just wondering too, I know both of you answered some questions in the Q&A as well. Was there any ones in particular on that list that you wanted to kind of emphasize out loud? I'm just kind of looking through the list here and just making sure that those questions were also given the airtime.
I think the one that keeps showing up a little bit is kind of speeding up the dose for the second dose for children under the age of 4. Kind of off the vaccine schedule and that piece. I would still say that as Dan had mentioned, there is still a significant protection from 1 dose of vaccine in a young individual. So that's why the publicly funded vaccine schedule is made as it is. There may be individual circumstances to talk individually about, but for the vast majority of kids, staying on schedule is probably going to be significantly protective against measles, especially, that just from a workload perspective, getting kids in early, and then the MMRV issue about missing the V. There are some challenges with kind of moving up the dose, but individual circumstances may warrant it in certain situations.
I'll just add quickly, Ali, that the Ontario Immunization Advisory Committee is going to be reviewing, if just given the current context of measles globally, if there is any rationale in moving it up for the population or for specific populations. So we'll have more to come on that in a couple of weeks.
Fantastic. I'm just going to also highlight just a couple questions, Zain, that you had answered with regards to COVID, just to give that a little bit of airtime as well. So with regards to the question about long-term effects with multiple COVID infections, just so everyone's clear, Dr. Chagla had written that reinfection, hospitalized complications are lower even in high-risk populations like transplants. And there are some studies that suggest a higher risk of cardiac issues, although there are some selection biases there. Other data is suggesting that the long COVID rate is lower. And at the end of the day, every respiratory virus with reinfection does carry risk of complications similar to influenza and RSV. Anything to add there?
No, I think that's it, right? So there is still important pieces about that spring vaccine campaign in high risk individuals in terms of even if they've had COVID, but aspect, but recognizing that we are reinfected with flu intermittently, and there's still a cardiac risk associated with those reinfections. So even though it's maybe lower risk, there's still risk.
Excellent. And then the other one here that was commented on was just around, is there the potential for a spring or summer COVID wave? And I think you spoke to that a little bit during your talk, but just to emphasize again that there are variations of JN1 that are emerging globally. And so this continues to be monitored, and I guess stay tuned is essentially the answer.
Yeah, exactly.
Okay, perfect. So with that, just keeping an eye on the time, I'm going to move things along to the next topic, onto menopause. But of course, if people still have questions, our panelists will continue to answer them in the Q&A. And if we have more time at the end of the session, we can always go back to some of these other questions. So with that, I'll turn things over to Dr. Goldstein for the menopause talk.
Good morning. So today I'm going to talk about a quick and simple approach to menopause management using some new online tools called the MQ6 tools. Next slide. This is the website, www.mq6.ca. Stands for Menopause Quick 6. The website has a lot of content and includes the MQ6 tools that were published in the 2017 Canadian Family Physician publication. And the content is really aimed mostly for healthcare professionals. The recommendations and the content are evidence-based, and uniquely, this is a peer-reviewed website. I'm going to introduce you to a few of the tools. Next slide. The first tool is the MQ6 screen, or the MQ6 assessment tool. MQ6 stands for Menopause Quick 6. These are the key questions to ask perimenopausal and menopausal women in assessing their need for treatment according to the guidelines from all over the world. 6 questions. First one, any changes in your periods? This helps rule out postmenopausal bleeding. You will have patients that say, last period was 4 years ago, but I did get some bleeding 3 months ago. They don't think to tell you about that postmenopausal bleeding, so we need to ask. Question 2, are you having any hot flashes? Questions 3 and 4 relate to GSM, genitourinary syndrome of menopause, any vaginal dryness or pain or sexual concerns, and any bladder issues or incontinence. GSM will occur in up to 50% of women, and unlike hot flashes, which will go on an average of 7.5 years, GSM is the gift that just keeps on giving. So you want to intervene, and you want to intervene early. Questions 5 and 6, how's your sleep and how's your mood? Now, this is the original MQ6. You can see open-ended questions, basic language. It's meant not only as a screening tool, but also as a tool to help the conversation going with your patients. You will find it on the website. It is a validated tool, and you will also find some new binary versions of the MQ6 with yes/no answers that have fillable PDFs where you can complete them online. You click yes and no. You can print them off. You can save them. You can scan them into your EMR. Next slide, please. If your MQ6 screen is positive, then the second tool, also from the original publication, it was updated in 2023. As you can see here, so all the questions are now in blue, and there is one new question that I'm going to talk about in a minute. So this treatment algorithm is essentially a decision tool. And what's new is that we have now used the logic from the algorithm and created an online decision tool, interactive. It acts like an app, and I'm going to describe that to you in a moment. Next slide. So you go to the MQ6 website, to the For Healthcare Professionals button. You'll get a drop-down menu. Click on Interactive Treatment Algorithm, and you'll get to this page with the big blue button in the middle. Now, the app is not something you buy from the Google Play Store or the Apple Store, but rather the software is embedded in the website. You create a shortcut to your phone, as I've done here on the right, and you see the icon, or you can create a shortcut or bookmark to your computer or other device. And that's how we kind of appify it so that you in future can just click on that button and it will take you directly to the tool itself. On this website, on this page, you can see where it's circled. There's information on how to download the app, i.e. how to create these shortcuts. Next slide. But you don't need to have the shortcut. You can go at any time, just go to the website, go to this page, and then click on the big blue button, and it will take you to the beginning of the online decision tool. You'll know you're there because you'll see this start button. So let's press start. And it will take you to the first step in the algorithm, which is hormone therapy indicated? You'll see this is the phone view. It gives you indications for hormone therapy. There are some hovers that give you extra information for explanation and talks about choosing a patient and who are the ideal patients. Each page has a yes or no button at the bottom and a next button. Next slide. Second step, is GSM the only indication for treatment? So if it is, the app will now take you out of the algorithm and directly to a page that has a listing of products and doses for GSM treatments. So this is a new step in the algorithm for 2023, because truly, if GSM is the only indication, you don't need to go through the rest of the algorithm. Next slide. Are there contraindications to systemic hormone therapy? So they're listed here. They're on the website, on the app. They're on the paper PDF version of the algorithm if you print it out. And you can compare that to your cumulative patient profile, or just ask the patient the questions as you're there. Next step is comorbidities. So comorbidities are conditions that increase your risk for clotting. They're not contraindications to treatment. But if you have a comorbidity, guidelines recommend we use a transdermal estrogen to avoid the first pass metabolism through the liver, and a less atherogenic progestogen, which is micronized progesterone, if you can. On this list, in addition, malabsorption is there because if you can't absorb oral hormones, they're not going to work, and gallstones because we know that oral estrogen does stimulate formation of gallstones. Next slide. Fifth step, does a patient have a hysterectomy? You need to consider the need for endometrial protection. Next slide. And the sixth step, and the last one, and you'll see after that you just push finish. When was the last menstrual period? If it was more than a year ago, then the patient is postmenopausal and you're going to use a continuous regimen. However, it's been less than a year, the patient is perimenopausal, you're going to give a cyclic regimen. That means estrogen every day and a progestogen for 12 to 14 days of the month. That should be followed by a predictable withdrawal bleed. You do that for a year, and then you can try and switch that patient to continuous regimen. Next slide. So after you finish, it will take you to an answer page with an individualized recommendation. And that's why I like the app over doing it manually with paper. It also, as you can see there, it says click here. That is a hyperlink that will take you to a table of treatment options with doses and options for this particular patient. The answer page, the left side shows the view on the phone, the right on the computer. It gives you rationale for the decision, things that you should be considering, and also to remind you to consider GSM once again. If you prescribe lower than what we considered standard doses of estrogen, her hormone therapy will not have a lot of benefit below the waist, i.e. for GSM, and you may need to add in additional local vaginal treatments. So what are the standard doses? And they are on the site here. So oral conjugated equine estrogen 0.625, oral estradiol 1 milligram, or transdermal estradiol a 50 milligram patch. Those are standard doses. Below that, you may need to add in vaginal estrogen. Next slide. So let's use a case and show how it works. This is Dr. She's a Sweatin. She's 49. She comes in for a pap smear. You need a minute and a half. You give the MQ6 screen. You find out her last period was 8 months ago. She has vasomotor symptoms. She has GSM. She has sleep issues. Her history and physical are significant for controlled hypertension. Her lab, she has normal lipids, normal sugar, and her mammogram and pap are up to date. Next slide. So let's try it and see how it works. Play. Hormone therapy indicated? Yes. Local symptoms, GSM only? No. Contraindications? No, she does not. She does have comorbidities? Yes. She doesn't have a hysterectomy? No. And it's not been more than a year since her last period. It's now going to think. And you can see this took 20 seconds and you get your answer page. Next. So for this patient, it recommended a cyclic regimen containing transdermal estrogen and providing endometrial protection. So we gave her estradiol 37.5 milligram patch twice a week, micronized progesterone 200 milligrams daily, day 1 to 13 of the month. That's how you write it. And then because I'm under a 50 milligram patch, I also added vaginal estradiol 10 micrograms nightly for 2 weeks and then twice a week. Next slide. So with the perimenopausal patients, can you treat them? Yes, even if they're bleeding. Do remember contraception. Hormone therapy does not provide contraception. Here's your pearl. Fertility persists for 1 year after the final menstrual period, but for 2 years after the final menstrual period if it occurs in your 40s instead of your 50s. And those patients may need contraception. So you can use cyclic E+P, but you'll need a backup such as condoms. You can use estrogen with a progestogenic IUS. So the Mirena off-label has been studied for 5 years and shown safety and efficacy along with estrogen as menopausal hormone therapy while giving you the benefit of contraception. You also can use a low-dose combined hormonal contraceptive if there are no contraindications. Remember, the doses of the CHC are about 4 times as potent as the amount of hormones that are in menopausal hormone therapy. If your patient can't use estrogen, the guidelines do say you can use a progestogen alone. Remember that that is off-label. Progestogens are indicated for endometrial protection. You will get some benefit to vasomotor symptoms. The data, they looked at studies with 300 milligrams of micronized progesterone nightly, and the data for postmenopausal women showed benefit. The data in perimenopausal women didn't quite reach significance statistically. So it can work. We don't do it a lot. We do see a benefit for sleep, particularly with the micronized progesterone at that higher dose. Next slide. So how do you choose for the postmenopausal women? Continuous, either E+P or one of the 2 tissue selective products that we have that do not require additional progestogens. Remember, progestogens stimulate the breast. They give you breast pain and other side effects. Dense breasts are associated with breast cancer, harder to read mammograms. We know the synthetic progestin in the Women's Health Study was associated with an increased risk of breast cancer. So if you want breast neutrality, you may consider one of these products. And the 2 we have in Canada are the TSEC, that's conjugated equine estrogen with basodoxifene or Duaviv, and the Steer, which is Tibolone. This is a synthetic sex steroid that has estrogenic, androgenic, and some progestogenic activity. That's Tibella. These are both once a day oral, same dose every day, postmenopausal hormone therapy that do not require additional progestogens. So who are we going to use it for? We have a patient who has baseline dense breasts, or they have breast fear, or they have breast pain, or they have a family history of breast cancer. The other group that these are preferred for might be those when you're worried about the bleeding profile, because we know that these products do have more favorable bleeding profiles. They'll take you to amenorrhea faster. They have less breakthrough bleeding. The other thing to consider would be with the Tibolone in particular, is that in Europe it has been used for libido because it does have androgenic properties. That would be an off-label indication here in Canada. Next slide. Last tool is a counseling tool. My peers say that once they figure out how to prescribe, they don't know what to say to patients. So I created this tool. It's got tick boxes. It tells you everything you need to talk to your patient about in terms of how to start hormones, risks, benefits, addresses breast cancer risk, strokes, clotting, and a number of other things. So you can go through this page with your patient. You can print it out and give them a copy. It's on the website. Next slide. A reminder that on the website, you will find full hormone and non-hormone tables with products available in Canada, along with doses. It's updated yearly. There is a section on the Women's Health Initiative with some information about that, some other information. There's a great page with frequently asked questions for troubleshooting and helping you just finesse your prescribing. It answers, common things I'm asked. And my favorite is the menopausal health promotion page. This talks about how to optimize and maintain your brain health, bone health, and cardiovascular health based on the most recent guidelines and recommendations. I like this one because even when I do physical, I'll talk to a patient about exercise, lifestyle, vitamin D, whatever, and then I just send them to the website because half the time they don't even remember what I've said to them. This is in writing, they can refer to it. I even use it with my male patients during their checkups because good health is good health. Next slide, please. These are my references and some of the guidelines, and if you're bored, weekend reading. Next slide. And I want to thank you for your time and for listening. I hope you will try out some of the tools and will find that they are helpful to you. Thank you.
Thank you. That was perfect. So thank you for that wonderful presentation, and you'll see a lot of comments in the chat. And I will share as well too that I personally have used this tool many times, and it's honestly been a game changer both for me and my patients in terms of the quality of the counseling and how comfortable I feel doing it. I mean, before I used to actually refer my patients to gynae because I was scared of starting it, and this really helped me bridge that gap. So thank you for that. In terms of the questions, I wanted to maybe flag actually some of the ones that you already answered that I think were really helpful for the group. So just give me one quick second here. So one of the questions that came up was with regards to weight and weight loss in particular. So one of the people here was asking if you could talk about the role of exercise and food with respect to menopause, and there was some mention too of cortisol levels as well too, but really that lens around weight gain and whether there is evidence about it helping with weight loss.
So sad to tell you, it doesn't really. What happens is you do see anywhere from 5 to 10 weight gain, pounds of weight gain during menopause. It's not really attributable to menopause. It's attributable to aging and the fact that as you drop your estrogen levels, fat cells are estrogen dependent. So what you get is weight distribution, and we all get that. We hate it, menopause middle. So there's some evidence that if you put women on hormone therapy early, you may delay that switch and that redistribution of fat. So people say, oh, it helps with weight. It doesn't really. What it does is just temporarily delay the redistribution of the fat. So just based on metabolic rate, if you do nothing and do everything exactly the same, you will gain a pound a year, or 10 pounds a decade, just due to metabolic slowing that's associated with aging. And most menopausal weight gain is associated with aging. So in the early 40s, you should tell your patients, look, you need to make sure you keep your exercise up. And as you get a little older, you may find that you need to eat just a little bit less. And you'll notice they say little because what happens if people overdo that and they really start to restrict, your BMR will reset itself for that semi-starvation state, and then you just hit plateau and it gets really frustrating. Someone did ask about, the metabolism of the cortisol. I don't have enough information to answer that. I'm sorry.
That's totally fine. That was a great answer. Thank you. Another question that you answered in the chat that I'll read out as well is someone had asked about the safety of topical or vaginal estrogen in a breast cancer patient who's also on letrozole, which I'm sure many of us have seen in our own practices. Is there any concern about that person using topical estrogen? And so you had commented that you can use vaginal estrogen for breast cancer survivors if they are not on aromatase inhibitors. However, that being said, it's always a good idea to consult with the patient's oncologist as well. With aromatase inhibitors, you usually don't want any added estrogen, so that's when it would be contraindicated.
Correct.
Perfect. Thank you. I'm going to, what I'm actually going to do is I'm going to quickly just highlight a couple other slides just before we finish the core content for 9 o'clock, and then we're going to come back to Q&A again to close out the session until 9:15, okay? So the next slide I'm going to present is just on behalf of the VaxFax clinic. This is based out of the Scarborough Health Network, but it is open to all patients from around Ontario. And essentially, the patients can call and have a phone conversation with an expert physician to answer vaccine questions. And I did confirm that they do provide counseling around measles vaccination as well. So if you're not sure or you don't have the time necessarily to do this very detailed discussion with a patient, this might be a good resource to send them to. I also confirm that it does not cause negation to foes, so you don't have to worry about that either. Next slide. And also, in addition to vaccine counseling, they also provide counseling for cancer screening and preventative health. So a really great provincial resource that's available. Next slide. And then another reminder, too, about the Can Treat COVID clinical trial that's going on. If you do have patients who test positive for COVID and they meet the eligibility criteria, they can be referred. And there are compensations both for the healthcare providers who refer, as well as for the patients who are participating in the study. And this is really important work as it allows us to determine if there are effective treatments for both acute COVID, but also long COVID as well. Next slide. I'll turn things over to Mekalai for this part.
Thanks. Just wanted to point out some of the OCFP supports for managing mental health, addictions, and chronic pain. You'll see our community of practice with a few different dates listed there. And then we also have our Peer Connect mentorship, which is a small group learning session and just a place to sort of celebrate successes and also deal with challenges that you may be facing in practice. And the deadline for that is April 12th. Next slide. And I'm just wanting to mention that our awards program is open, I should say. We know that there are so many amazing family docs across this province, so I'd really encourage you to consider nominating one of your colleagues or someone you see doing great work. And the deadline for nomination is March 31st.
Excellent. So if we can just take the slides down again. Perfect. And we'll go back to Q&A just to close some things out here. And again, for those who do have to leave at 9 o'clock, this session is fully recorded. So you can always view this extra Q&A afterwards when you have some more time. So with that, I'm going to turn things back over to you, Dr. Goldstein, with some other questions related to your excellent menopause talk there. So one of the questions that came up here is how do we ensure that you have enough progestin protection for a given dose of estrogen? Is there a rule of thumb in general for that?
So it's an excellent question. It is proportional. There isn't actually an easy table for us. So go by what's standard. So for example, if you have a 50 milligram estrogen patch and you're going to use micronized progesterone, you would be using 200 milligrams a day if you're doing a cyclic regimen, like day 1 to 13, and you'd be using 100 milligrams a day if you were using it daily in a continuous regimen. So in theory, if you halved your estrogen, you probably could half your progestogen, more or less. Often what I'll do is I go to lower doses. I may give progestogen, or day 1, Monday to Friday, rather than all 7 days. And there's 2 reasons for that. One is you need less progestogen. The second is that for breast safety, the evidence indicates that you have better breast safety, believe it or not, when you use pulsed or cyclic progestogens rather than continuous progestogen.
Great, thank you for that. And this kind of feeds into another question here, which is in the perimenopausal period, is there benefit with progesterone alone in that period?
I'm so glad you asked that. That is the best question. That is the hot topic today. So this is how it goes. It is actually not simple. So progestogen alone is on the list. It's in the guidelines as an option for treatment for vasomotor symptoms for the perimenopausal patient. However, you have to remember that the use of a progestogen in that group is actually off-label. Indications for progestogen is actually for endometrial protection. Now, this is what we know. We know that progestogens are sedating. A lot of people have sleep issues, and there's been a lot out there now about using progestogen for sleep, particularly micronized progesterone. Yes, it does help sleep for sure. In terms of the data for vasomotor symptoms, in postmenopausal women, there is evidence that you actually get significant reduction in vasomotor symptoms, not as near as robust as using estrogen. However, in the perimenopausal patients, if you use the micronized progesterone, while it trended in the studies, you didn't actually get to statistically significant reduction in vasomotor symptoms. I've spoken to my colleagues. We use it rarely, to be honest. The efficacy for the vasomotor symptoms is a bit hit and miss, but people love the sleep benefit. So what are the downsides? Because that's the benefit. The downsides, first of all, are the progestogenic side effects, because the dose in the studies was 300 milligrams continuous nightly of micronized progesterone. That's a fair amount. It's going to zonk you out. We know patients on 100 or 200 who are sedated, and we have them use the capsules actually intravaginally because it's too sedating when it's oral. Progestogen, and that's safe. Progestogenic effects are also bloating, water retention, headache, breast tenderness, moodiness. So you may see any or all of those when you're given this whack of progesterone. The other part has to do with breast safety. Simple answer is we don't really know. When it comes to the synthetic progestin, hydroxyprogestin acetate, which is Provera, we know in the Women's Health Study that was associated with increased risk of breast cancer. But the question is, what about other progestogens? So micronized progesterone was studied, E3N study in France. It's a observational data. And when they compared different regimens with different progestogens, micronized progesterone appeared over 5 years not to increase risk of breast cancer compared to the Provera, which did. But it is observational data. So I give you all of that, and then each person has to decide if they're going to prescribe this off-label. You know the risks and benefits of doing so.
Great. Thank you for such a comprehensive answer. That's super helpful to help kind of navigate that muddiness as you mentioned there with it. So thank you for that.
Yeah.
In terms of another question here, which comes up commonly, is how do we know when to stop? So do you have any advice in terms of weaning off, or is that part of the tool?
It doesn't need to be. So here is the bottom line. As you age, your risk of stroke goes up. You're on hormones, there's theoretical risk of clotting. All this scary stuff about heart attacks and stroke occurred in the Women's Health Study in older women. So there is actually no year or date you need to stop. So the first thing I must say is you can kind of predict how long you need it for. So women who start having hot flashes after their periods have already stopped, on average, they're only going to go for 3.5 years. But women who start getting hot flashes while they're still bleeding and all of that, the study says that's over 11 years. So when you're counseling women about length of duration of treatment, consider that at that point. You go so the median is 7.5 years. You go until you think they don't need it. There is a guideline from the US that says you can clearly go after 65. You just have to annually review the patient, the risk profile, indications for treatment. So there's no rule, please, that says, oh, when you hit 60, you have to stop. That comes from old data where we used to say it's safest under age 60. No, it's safest when initiated under the age of 60. But as you get into your mid-60s, the guidelines do recommend try and decrease to the lowest effective dose. And ideally, if they're not a transdermal at that point, try and shift them to transdermal, because we know in older populations, the evidence is that transdermals are safer in terms of benefits and not causing clots. But it's in the older populations. In the under 60s, we actually don't have that data. Because a lot of people ask us, oh, aren't transdermals better for everybody? No, we don't have the data to say that that is true. Most of us will try and get people off, by the time they hit 70, because their greatest risk is actually stroke, which comes with age. But you're going to have 10 or 15% of people that can't come off it, that will have persisting hot flashes. So there is no time. That's a rule to stop. When you stop, it does not matter whether you taper or you just go to cold turkey. I recommend tapering, because sometimes when you taper down, you hit a sweet spot where symptoms come back and the patients don't want to go off it altogether. And at least now you know what the new dose is that you need.
Great. Thank you for that. That was very clear as well. So appreciate that and all the nuance that you mentioned there. Now, another question that comes up often is around blood work. So, should you be checking people to confirm that they are actually going through? I see you shaking your head. So maybe you can just clarify that for us in terms of when, if ever, we should ever be doing blood testing.
Okay, so if you have young patients, and we have not talked about earlier premature menopause, so under age 45, those women should absolutely be treated, and they should be treated until the age of 51, which is the average age of menopause. And then you reset the clock, because someone asked about that. If you hadn't treated them in their early 40s and you're 10 years out, it's too late, the boat is missed. So having said that, oh my God, I forgot the question. Sorry.
Sorry about blood work. Like whether or
Yes.
not.
Okay.
Yeah,
So that group may, you may need to do FSH, LH, estradiol, TSH, prolactin to determine is it really menopause because they're young. But otherwise, menopause is a diagnosis that is a clinical diagnosis. If you do hormone levels, they'll bounce all over the place at any given time. They're just, especially the estrogen levels, are not really that helpful. Sometimes you do it because somebody has an IUD and they're not sure what's happening because they're not bleeding. If someone didn't have symptoms and all of a sudden has symptoms and you're not quite sure, you may do it. But in general, there's not really a role to do any of the hormones. And even testosterone, we don't do it. We don't do it for libido. You only do testosterone level if you're thinking of treating for libido so that you get a baseline, but it's not diagnostic in any way.
Great, thank you. The other question I had here was, here we go. So sometimes there are compounded estrogen creams that are prescribed by naturopaths or other, providers, not necessarily medical doctors. What's, how do we navigate that? Is there any benefit with those formulations? Any advice that we should do in those scenarios?
Okay, so we have what's called body identical hormones. So if you want to give the same hormone that the body has, which is, these compounded things are all saying they're bioidentical. Well, they're still formulated in a lab. It's not that they are, but if you want to use body identical estradiol, that's body identical. If you use micronized progesterone, that's progesterone. That's body identical. And those both are pharmaceutically tested. You've got control. The guidelines all recommend to stay away from the compounded. So when people talk about natural or bioidentical, they mean the compounds. And the guidelines there's all kinds of evidence that you don't have batch safety, you don't have proper labeling. They've done crazy studies where they've shown that the amount of hormone in some of these compounds goes from 0 to 20 times or more what's supposed to be in there. The real worrisome one is progesterone. Progesterone is a big molecule. It is hard to absorb it through a cream. And these compounded creams have not been tested to see if you actually are absorbing the progesterone, which means you don't know if you're getting endometrial safety. We've seen lots of cases with these compounds with endometrial cancer. So that one is a big no-no. So if someone wants that, we tend to say, use the approved medications and just choose those ones that are body identical.
Thank you for answering all those questions, Dr. Goldstein.
Welcome. Thank you for having me.
No problem. So can we have the slide deck up? Perfect. I think it's just loading there. Okay, so in terms of recent sessions, so there are previous webinars and related resources that are posted on our website. So if you do want to go back and see any of our previous talks on these topics, please feel free to check them out. Next slide. And in terms of previous sessions, as I said, they're all listed there on that particular website. Next slide, please. And finally, a webinar recording and the Q&A will be posted soon. Our next Community of Practice will be on April 5th, 2024. And again, I want to thank all of our panelists, our entire team for putting today's session together. And thank you all for all of your wonderful engagement. This was great. And look forward to seeing you soon. Take care and have a great day, everyone.